4:15. Let's just cover a couple more topics. Go for lunch. Alright. Page 423. It'll say, this is all the same chapter. They combined it all into one chapter now for male and female. It's chapter 57. So look at page 423.
I'm sorry, I have a question.
Yeah.
For the complications where it says vasovagal response, it just says cardiac sedation. What does that mean?
For which one?
For the complications of
A vasovagal response is depending, usually it can also be through the rectum. The vagal nerve runs down. So if you stimulate too much with movements, and this can be from either anal stimulation or vaginal, you can have a vasovagal response in which if they have a cardiac condition, it'll stimulate their heart. So that's why they ask for medical history. But probably one of the least expected things to happen. This can also happen from like a vagal response or anything else happen from when people strain too much to poop, right? They like really press down. They can either slow down their heart rate too much or they can even pass out from that vagal response. If you're like trying too hard. Generally, it's if you already have a heart condition, but the vagal nerve can be stimulated nonetheless. How severely and how much you stayed, like how severe the reaction is, can be based on your heart condition. But you can do it nonetheless. Right. Right. And so a vagal response, if you have asymptomatic, like supraventricular tachycardia, their heart is beating, right, but they're still awake and conscious and they're kicking it. What you can like do, or they'll do them in ambulance, I can show you guys a video, I usually send it to people. The first thing people do is medicate them, right? But this is for emergency. If they're asymptomatic and there's not much to do, or you're like on transport or anything, you can try to do this. You can try to stimulate their vagal nerve by bearing down, like what I'm describing. So one way to do that is, you guys know the piston syringes? Or they can use their thumb. You're gonna ask them to like blow. Like they're gonna try to like blow their thumb out, like just really, really, but obviously they can't. And with the piston syringe, right, which used to flush the G tubes, if you extend it and you try to blow, you're not gonna pop that thing out with blowing it. So what you do is tell them as hard, like you gotta try, blow it out, or their thumb. And so they'll look it up, right? And so they're creating all this pressure, and they're bearing down, they create this pressure, and they hold that quite a bit, and then you flip them upside down. You help pick them up, okay? And they stimulate the vagal nerve, and the tachycardia comes down. I've seen it in a doctor's office on video. Now, we didn't cover this in cardio. Term 3, vasovagal stimulation. Yes, no? So for certain tachycardias, you can do that. For like SVT, that's asymptomatic. That means they're okay. They're not like immediately having something.
What if it lands on you?
Huh?
What if it lands on you when you flip them?
What lands on you?
The poop.
They're not poop, but no.
What?
No, they're not bearing down like that. Like that's what you tell them to blow in a syringe. No, hold on. Let me finish. I said if you try to poop too hard, it can happen. The stimulation. But they're not trying to poop right now. Instead of trying to poop, the other way you can create that tension is blow in a syringe or your thumb. You get me? So the same thing, like you can try it right now. Obviously, all of you know how to try to poop, right? You're trying to force it, but grab your thumb and just, all right, you guys just sit out. You forced before, don't lie. All right. Let's zip it up. In the front. All right. Let's relax. So, I said bearing down, so trying to strain can cause vasovagal stimulation. It was one of the complications. You can also just do this from, that's why when you guys disimpact people, right? Like when they have poop stuck and you're digitally disimpacting them, you can also have them pass out. Because of the fact that if you cause, the vagus nerves runs from a cranial nerve onto the bottom portion of the body. So it'll stimulate it. And if you stimulate it enough, people can pass out or they can have a cardiac dysrhythmia or some sort of cardiac event. Now, you can do this from stimulating the rectum. In this case, it was vaginally, since it shares the rectal wall. You can do this from bearing down, like as I said, like if you're trying to poop, right? Like you bear down too much, people can pass out. So then, that's where he got the trying to poop. But I said, if they're asymptomatic ventricular tachycardia, what you can do to try to bear down, instead of trying to like bear down like that, you grab a syringe and you have them blow into it because they won't be able to blow it out. But like I said, if you want to try it right now, if you try to blow really hard into something, right, like your thumb or a syringe, you're going to then create that like, right, like your body tenses up. So as they hold that tension and then they flip them, right, they lift their legs, that'll stimulate that vagal nerve and that should slow down their heart. Okay. Majority of the times it doesn't work. Okay, it won't slow it down. So that's how they use medication. And a lot of the times, even though it works, it's temporary and they'll convert back either way. So it's only like a temporary help. So that's why it's not a common practice. So you don't hear about people getting like flipped over and stuff. They just give them amiodarone. It's very like it's a lot easier. Huh? Or it could be adenosine if you want to like give them down. Depends on dysrhythmia. So they're in AFib RVR, right? And that. But for SVT, you're right. It is adenosine, not amiodarone. So it all depends. Now this again is a cardiac talk and it's irrelevant. I got off topic, so I'm sorry. But it all started because of the vasovagal stimulation. It just sex can stimulate the vasal. Hence again, if you're having anal sex or vaginal sex, depending on the position, you can have vasovagal stimulation. Yeah. Alright. Let's cover mammography and then we'll go. Page 423, mammography. Now in the beginning of the chapter, if you saw, it talked about breast exams. We'll go over more so a self-breast exam during cancer. And it's also just not recommended. Mammography is the one that's recommended for screening for cancer. Self-breast exams are just breast exams where you palpate. These can help you feel out masses, but if you already have a mass, you already have a mass. So mammography is usually is the one that is recommended. It's the screening that is done because mammography can actually catch the cancer even before it's palpable. Okay, so it's earlier detection. This is page 423 in chapter 57. Mammography. So let's read through it. During a mammogram, the breasts are compressed vertically and horizontally by the mammography machine while radiologic pictures are taken of each breast. Traditional mammography images are stored on film or XYZ. So, several organizations provide guidelines for this. You have to know the screening guidelines, like your pages. Okay? So here it is. Clients who are 40 to 44 years of age should have the option to start screening. Clients who are 45 to 54 should obtain them annually. Clients who are more than 55 can switch to a mammogram every other year, or they can choose to continue them yearly. Routine screening should continue for as long as the client is in good health and expected to live at least 10 more years. So, 40 to 44, I think is what it said, right? Again, 45 to 54, annually. More than 55, every other, which means every 2, or you can choose every 1. Because if they're healthy and continue to live for more than 10 years, this is recommended. If their life expectancy is less than 10 years, especially if it's less than 5, you're gonna go through all of that for a mammogram and like they're gonna probably die sooner than any breast cancer could possibly like. It's not, the risk no longer, the benefit no longer outweighs the risk or the need. So those are your guidelines. Obviously people can do what they like and how they like, but these are the guidelines that you must know for your So that's step one. Just what is it? How often do we get it? Now, as I explained, it's put into like a contraption almost of sort, right? Like a machine, vertically and horizontally. The breast is compressed. Okay, so like these push inwards, right, towards the breast. They compress the breast, and then radiologic X-ray pictures are taken. These will detect any masses within the breast. Okay, just detect for cancer. Now again, mammography can detect cancer before it's palpable. Palpable means you can feel it. So a lot of people just feel their breast, right? You're taught how to do this at home. It's good, but again, you should, the mammogram is not only more adept at detecting it, it can detect it before you can with the, and it could just be a mass. It doesn't have to be cancer. If, the what? 7 years? If you're gonna live less than, I should put, less than 10 years, you don't have to have a mammogram no more. If they're not gonna live longer than 10 years. Okay? Indications. Detect unexpected findings. Cancers, lesions, right? We said tumors, cysts. Screening mammograms are gonna be, to detect the cancer lesions. Diagnostics are when it's suspected, now they're gonna get more images for it. Now there's a big table, I'm not sure if it's in the ebook, but in the book is a big table, so we continue on to page 426, or if it doesn't for you on the ebook, look at client education for the mammogram. So scroll down or turn the pages, go to client education for the mammogram. Okay. Provide information, it says, about the procedure, what to expect. We talked about them, right? The breast will be compressed, there'll be a bit of discomfort or have a little bit of pain. Okay. Potential discomfort during the procedure is the second point. And here's a big one. Avoid the use of deodorant, lotion, I think it says powders too, no? Powders. Okay, basically anything in the axillary region, that's here, right here, what you refer to as the armpit, okay, or on the breast prior to the exam. So on axillary or breast. Okay, pre-procedure, inform the client to disrobe from waist up. Instruct the client to point to any areas of concern. These will be further examined. Intra-procedure, again, the radiology tech will do everything. Intra-procedure, nursing actions are rarely done. Post-procedure, allow them privacy to redress. Privacy. So this is like, essentially this is an x-ray, okay? So, the biggest thing is the instruction of the pre, which is, I can't emphasize that enough, the lotion, powders, deodorant, don't apply anything prior to the exam. So that morning of the day before. Or especially the morning of, don't apply it. Okay? The other thing apart from what not to do is the screening, the years. When do they begin? When is it annually? When can they discontinue? Questions? Okay. All right. So I'll bring up another point that we see the concerns of many and myself. I haven't had to do it the last two cohorts, but I did for one. Now, I don't mind where you guys sit. By ACC, you should be alphabetically. But I'll tell you my situation on it. if when I'm lecturing, all right, your signal to just be quiet, you guys can actually be quiet how you usually are, and I appreciate that you guys usually are, then great. But if there's like a lot of side talk or things like that during it, or trouble getting back to lecture, the first step is, I don't single people out, that's unfair. So we'll have the entire class sit alphabetically. And after that, because you are now in a new seat, then you'll be written up individually because now you're deliberately going out of your way to talk. Again, it can all be avoided if we just wrap it in soon, and then during the lecture just avoid the chatter. Because if you notice people where I can't hear, or I can't hear questions, or I can't get the point across, people are missing, and then that'll create for too much misinformation for the text. Agree? Again, it hasn't had to happen. Most people once we say this, it's fine. Or should it continue to be a problem?
No, I'm from consent phase, right?
For the mammography, no. Not that it's listed, so I'm gonna say no. You good? Alrighty. We're a few minutes early. We're currently 3 minutes. Be back at 12.